Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Well, welcome everyone to another episode of The Pursuit of Health. I'm your host, Rainer Schur, and back on the show today is Jared Rhoads. Welcome back to the show.
Thanks for having me.
So today we're again going to delve into the realm of action. Jared, you've had the opportunity to speak on another healthcare bill, this time in New Hampshire. This was quite a while ago now, but it's still very relevant to what's going on in debates about healthcare and especially on how it's being paid for. So before we get into the bill itself, let's talk about the general topic of the bill. It's about how healthcare is paid for. Now, there's this thing called direct pay, and that can refer to different things. What does it generally refer to in the healthcare space?
In the healthcare space, direct pay would imply that you are or you're directly paying for the care that you're receiving. Maybe it's a procedure, maybe it's a small surgery, could be an imaging, whatever the good or service is that you're buying, that you are paying for it, and you're not using insurance. That's the basic. That's the basic idea. So you're not going to like submit this bill to like an insurance company and then have them pay it, or you're not going to get reimbursed in some way. It's that you're the one paying it. Maybe it's literally cash, but it could also just be something like you're putting down your credit card to pay for the good or the service. The real thing here, the real essence is that it's not going through a complicated like a third party kind of process where there's additional administrative complexity, let's say, or contracts involved. It's just somebody involved in the chain is making a direct payment.
And you've already touched on this just now, but why is direct pay as a model important in our debate on healthcare reform?
Yeah. The reason it's a good thing, a good alternative to have is because right now the way that insurance is operating, there are definitely some complexities and some additional costs, some inefficiencies that happen in insurance. Now you and I, we're always careful not to, like demonize insurance companies necessarily, but inescapably there, if you are talking about like a third party kind of payment system, there's going to be at least some kind of additional administrative. Now, maybe you can do that really well and you can do it really efficiently, so that the third party that's getting involved is like totally very negligible, and it's fine. But I think there's a sort of a general consensus that insurance is maybe not working quite as well as it could in the US, and so there's additional complexity and additional cost. So having options out there that just sort of sidestep that whole dilemma, right? Like how do you do insurance well? How do you handle it well? How do you administrate that well? That's a challenge, and somebody needs to. There's probably room to do that better, like I said. So having some alternatives out there that just don't involve that at all, and go straight with a direct payment is a way of kind of testing another idea, and having, let's say, another consumer alternative.
When I first learned about this, I was quite surprised to learn that a lot of healthcare is regulated through health insurance, right? So if you therefore forego paying your services through health insurance, you can bypass a lot of those regulations, which is, I think, one reason why it's been picking up more steam. So let's get into the bill itself. So how about explaining to our audience what exactly the bill is trying to do?
Yeah. Yeah, in New Hampshire, it's in we sort of have an interesting scenario here where back in, I think it was about 2016 or so, New Hampshire did away with its certificate of need law. Okay, so I'm gonna have to sort of step back to kind of explain this a little bit. Um, but and so I would consider that a good thing. Certificate of need laws are these permission slips that you need from the government in order to expand a facility, or add new capacity in some way. Anyway, that's a whole other topic. But we basically in 2016 that was done away with. But at the same time, these other almost with the same stroke of the pen, um, these other requirements were put in place. And one of the requirements basically said that if you're going to open up a healthcare facility in the state of New Hampshire, let's say an ambulatory surgical center, or even like a dedicated imaging center or something like that, or a specialty clinic of some sort, you can't you can't only accept cash. Let me double click on that. Sometimes if I say that quickly or people are like half listening, they'll say, "Oh, you can't accept cash." Oh, that's weird. But no, no, no. What it is you can't only accept cash. So what that means is that you can't be one of these direct pay facilities, really. You can't set up and say we're going to be really efficient. We're not going to have lots and lots of people in our front office to working with insurance companies and working with all that paperwork. We're gonna really simplify this. And we're gonna our model, our competitive strategy here will be to sort of give some of those savings back to our patients and our customers in the form of like lower prices, right? And so we'll sort of say we'll sort of use that savings to lower prices. That's in the current status quo in New Hampshire. That's not allowed because you can't be a facility that only accepts cash and doesn't also accept commercial insurance and Medicare and Medicaid and other forms. So there's sort of the current law sort of forces you to accept lots and lots of different forms of payers, and of course. I mean, you could still accept cash if you wanted to, but that sort of defeats the whole idea of that like super streamlined model, where like if you can't just accept cash, well then you do have to invest in that infrastructure. You're gonna have to hire a few people in that front office, like I said, and you're gonna have to go through the contracts and set up the processes and the review processes and the paperwork and all that stuff. You can't bypass that in New Hampshire legally.
And I believe the legal requirement that you're talking about is called all payments. Is that right?
Yeah. Yeah. It's like an all payer kind of that's how we kind of refer to it around here. I don't think it's that widespread in other states. I'd actually be interested to maybe spend some time and try to figure out if how many other states have this sort of thing. It's not exactly a common kind of thing. Like I said, it sort of came out of like a almost like a fluke arrangement after the reform of the certificate of need laws. It's sort of an unusual. I don't know that New Hampshire is the only state, but it's not a common kind of thing.
I do think it is important, like you said, to double click and clarify what this really means. Another way to think about this all payment requirement is that it forces you to accept all forms of payment. And because different forms of payment have different strings attached to it, like regulations, if you have to take on insurance, it really limits your freedom to innovate with different models. Now, maybe I can see that where some of this might come from is that, oh, we don't want businesses to discriminate between different forms of payment, right? Because we want patients to be able to take their healthcare coverage or dollars and be able to go anywhere. But what that doesn't take into account is the freedom of the providers to offer different kinds of services that have different kinds of financial arrangements. And by getting rid of that freedom, you're also actually getting rid of the freedom for the patient themselves to be able to access those different kinds of services. Uh,
Right, absolutely. So if it's definitely it definitely limits those options if you're a consumer. I mean, if you live in New Hampshire and you wish that there was a cash-based place where you could go and get your gallbladder surgery for $7,000 instead of going the insurance route and getting the same surgery for $20,000, but then playing the game of like, well, it's 20,000 list price, but then there's this complicated insurance thing, and maybe I'll be paying this much, or I don't know what I'm going to be paying. There's all sorts of like uncertainty with that other path. Um, you don't have that option. I mean, I suppose you can there is a certain amount of like medical tourism you could go. You could go that route and you could go, travel, take it upon yourself to travel to another state where this is allowed, or even another country. I mean, medical tourism is sort of a whole other topic. And you could pursue it that way, I suppose. But like within the state though, you this is not an option for you. And that that can create a barrier right there to in terms of accessing care for people who would like to do this.
So, how did you end up arguing in favor of this bill?
I argued it from sort of a kind of a variety of stances. In my written testimony, I think I talked about choice and access to care. Um, I think in the Q&A part of that testimony, I think a few issues did come up that sort of touched a little bit more on sort of like the freedom of the providers to practice and set up a practice and or a facility the way they want. It's sort of, you kind of have to be artful in how you choose what you think is going to be convincing to that committee on that particular day. Um, one of the things that I know was on their minds, there was a few sort of like questions and objections, and sometimes it's like you're actually coming up against some resistance, and other times some of these questions are just sort of innocent or honest questions that they're curious about. For instance, I remember in the testimony there was a question that arose about well, what happens if somebody goes to a, a direct pay surgical center, let's say they get a surgery, but then the something bad happens afterwards, like there's like a adverse event in the weeks that follow or something. Like, won't they have to go back to, what'll happen to that person? Will they have to go back to the some other hospital then and get that fixed or something? And you could see how that's like something that might be on the mind of, I guess, a committee member, but it's not really a great argument or some sort of like revelation of a flaw with this idea. That kind of thing. I mean, first of all, direct pay facilities they tend to guarantee and sort of stand by their work because if anything, they know that there might be a little bit of a skepticism over, oh wow, your prices are so much less than the major hospital chain down the road. How is that possible? Maybe it's a quality thing, but well, no, it's actually it is the sort of administrative complexity thing that allows that price to be more competitive and lower. And so in order to sort of overcome any skepticism, they then like have a guarantee for their care. Hey, if something goes badly here, we'll work with you to provide the care necessary to see that you have a good outcome. So like sometimes the objections you encounter are things like that, which are interesting.
I think the case for this bill is pretty clear to me, but what was the main kind of opposition from other people that were testifying on this bill for why it shouldn't be passed?
Yeah. So that day, it was actually kind of interesting. There was some representatives from like the long-term care kind of world and nursing homes and everything. I actually think they were just misreading the bill.
Hmm.
That I actually think I would just sort of chalk up to I think there might have been some grammatical clauses in the writing of the bill that there's like it listed some things and then it said, well, but then there are some exceptions and it was maybe slightly ambiguous whether like did the exceptions apply to the first part of the sentence or the second part of this. It was one of those sorts of questions. It's just a drafting kind of issue, and they showed up to the hearing and sort of were objecting a little bit. I think that'll actually probably just take care of itself as just a drafting issue. I could point to there are other sort of more philosophical and more kind of fundamental concerns, at least that come up with this kind of bill. There can be concerns about like, well, aren't we creating like a tiered system? Or aren't we, could there be a cream skimming problem with this? Those are some kind of thoughts that some people,
Could you explain
might.
the cream skimming concern to our audience, what that is?
So a patient a consumer who is, willing to be a cash payer on some procedure or surgery that they're seeking, that I think a lot of hospitals would see that as, oh, that's a good patient. We'd like to have that patient. They would like to have that business. And I think the fear here would be, well, wouldn't if a cash only direct pay healthcare facility opened up someplace in the state, wouldn't that like attract all those patients? And that would be very profitable for that organization. But wouldn't that like pull people away from other hospitals, whether it's, regular hospitals or critical access care hospitals? Um, and I mean, there's a few different ways that you can, address that. On one level, you could say, well, wait a second. If we're talking about competing for to offer people the best outcome, and that's what they freely choose, like why is that a problem if it's if this new place operating in a new way is delivering better value? That's actually not a problem. Like that shouldn't prevent other we shouldn't squash down that in order to either prop up or protect other other facilities. It ends up, it can be a little bit thorny when you realize the extent to which there's like cross subsidization, right? I mean, there's facilities and hospitals that, they know that this part of their business is sort of done almost at a loss, and it's made up for by this other part of their business, which they make a lot of money on, and I mean that's oftentimes we can trace that back to interventions and policies that sort of force that weird system. I don't think a real market system would evolve that way. It's sort of maybe a topic for another day, but that's some of that sort of like prior complexity and problems with the way the system works sort of make some of these objections to other solutions seem reasonable, which is it's frustrating, right? Because we're often in the position to say, well, if it even sounds reasonable, it's only because there's this other distortion happening elsewhere in the system, and it's actually kind of one of the problems with doing health policy. One of the reasons that health policy is hard to do is because we're often talking about the need to like fix multiple things at once, and in bills, when you're testifying in a on a particular bill in a state house somewhere, those are typically aren't these like omnibus bills that make 50 changes. They're usually making changes one at a time, and so it can make the policy advocacy project a little bit difficult, but we do our best to battle through that.
Yeah, what I find revealing about the cream skimming kind of objection, and I see and hear it all the time, is that it's really reflective of not wanting to change the status quo. Sure, some hospitals might struggle to stay open if they lose customers with otherwise good health insurance to one of these direct pay facilities. I get that. But very often, these hospitals are also not super efficient. They're not super innovative. And then they can kind of use their own inefficiency and high prices potentially as a shield for not changing the system. And I think that that makes healthcare reform both challenging, but also it points to a potentially very strong argument that if the status quo truly is untenable, well, then they can't just keep appealing to it, right? Like they actually have to justify their own services and existence, and they can't just say like, oh, well, like we can't compete with these people who can sometimes even offer lower prices. And so
Right.
I think reframing it that way is one way to basically argue that you cannot use the mere fact that these direct pay models offer a cheaper better products against them.
Right, right. And it must be so easy to be somebody whose job is to kind of defend the status quo because you can always point out some theoretical, problem with some change, right? And a lot of these, even great ideas, you can frame them as a threat. I think what you're talking about is spot on, and it kind of goes towards why everybody who's contributing and collaborating with us at the Center for Modern Health, why we are trying to operate in both the world of doing good kind of like specific work on issues and bills and ideas as they come up, but then at the same time still be shaping like the broader cultural issues too, because that's the whole system in which you're operating, right? And you don't want to like let the opportunity pass by to like make an actual change. And for instance, this New Hampshire bill, if that were to pass, that would be a good change for New Hampshire. But you also want to keep the pressure on the shaping of the bigger macro issues that we're talking about here, because that's sort of like how you got into the problem in the first place, and it also shapes some of what your options are later on, et cetera. Maybe you can avoid some problems if we get a better approach to the macro issues. And so that's why it's just why we work on both things kind of simultaneously in a hopefully integrated and unified sort of way.
Yeah, and I definitely see the cultural component quite explicitly in this case because, as you mentioned, one of the responses that you got was, oh, so if someone goes to one of these facilities, will they be covered for other things, right? So if cultures is basically referring to like our background assumptions and values, people seem to compare any new idea with, oh, how are things already being done? Like, what are we used to? And part of what we're arguing is that, yeah, some things will be different, and that's also a good thing, right? Because the status quo is not working for people. So we do have to start questioning those background assumptions, in particular over how things are paid for.
Yeah, and if you're not accustomed to thinking of the market as a sort of opportunity identifying machine that and a mechanism that funnels both human ingenuity and human effort and investment and support into things as needed as opportunities arise, right? Like if you're not thinking of it in that kind of dynamic way, if you're thinking of it in a more static way, just what's going to happen, in the immediate aftermath of some change. You're not really realizing how adaptive the system could be if we let it be more free. Then I guess the skeptical approach. I mean, the skeptical perspective is a little bit more understandable, but no, we're here to emphasize the how adaptive and how innovative people can be out there if we let them be.
And so let's take a step back now to direct pay models in general. So if it's the case that how we pay for things, well, it's both a kind of cultural expectation issue, but it's also a policy issue where barriers such as the all payment requirement prevents different models. What other kind of barriers towards different kinds of payment exist towards this kind of model across the country?
Let me say this. Here's a practical barrier in the advocacy space. This is maybe not what you had in mind, but it's like the first thing that came to mind, which is that as we're telling these stories and kind of laying out the case for more direct pay to be allowed. I mean, certainly there's like all the certificate of need barriers and yeah, barriers that are in place in many states. That's one thing. In states where there aren't barriers and there actually are um, some functioning direct pay facilities, things are going well, but there's almost like a lack of data and understanding about that. Um, Oklahoma has, anybody who's sort of followed this issue before has probably heard of the Surgery Center for Oklahoma. they're a great case. A physician named Keith Smith and some colleagues started that up, 20 plus years ago. It does great work. Cash only surgeries, high quality, very transparent. All good things. Um, and but the thing is, like, no accessing like the data from their experience to present to committee members when we're trying to argue for the same thing in New Hampshire. There's like a sort of limited amount of information that we can get to satisfy those questions. The other thing is that even when we can use that as a really great example of, hey, here's a functioning thing that's doing well. It's been in existence for a long time. Lots of happy customers from that. We tend to continually cite it over and over again, and it would be great if we had more, like other variety of examples. That way, the skeptical committee member doesn't say, well, all of your information seems to be hinging on this one case. Aren't there other examples? But if other places aren't sort of telling their story, if they're not, either whether it's like, publishing up some case studies or allowing a think tank or some academics to do a quantitative analysis of their performance or something like that. Like that would help. Certainly the kind of advocacy and education part of this a lot if we had more of that information out there that we can present.
One area where I think there could also be more clarity is on the state level on allowing direct payment models. So, in the big beautiful bill, it was clarified that health saving accounts could be used towards direct primary care. They also imposed certain limitations on them, but they basically clarified that health savings accounts can be used for direct primary care. But what I learned recently is that there's still ambiguity on the state level in various states of whether or not direct care is or is not insurance. So it's not an actual ban. Like I'm in the state of Maryland, there's no ban on direct primary care. It doesn't say that direct primary care is or is not insurance. It's just not clear. And so that kind of legal ambiguity also scares people to get into this kind of model.
Right, right. That's totally the case. Who is going to what physician who is curious about starting up a direct primary care practice, who's going to invest all that time and effort in like actually making a go of it if there's always this question kind of lingering, the sort of Damocles, like at any given time, some regulator could say, "Hey, that isn't that insurance now needs to be regulated as such because you're making claims about being able to have unlimited visits, right?" So some DPCs set themselves up that way. They say, "Hey, there's no limit we're not going to limit you to like one visit a month or something like that, or one visit every 3 months. You can come in whenever you want." That's, to some regulators, that sounds like a claim of unlimited services, right? In which case they would say, that violates insurance regulations that are but that they shouldn't even be applied to that case. But if you don't know for sure, that's going to have a chilling effect on that whole thing in that state until it gets cleared up. So you're right. We've seen a number of bills and states adopt that kind of clarity, but there's still some to go, and still similar ones, barriers in the facility space as well. There's also other. I'll just say quickly too. There's other sort of just ordinary. Let's call them ordinary regulatory, kind of like facility regulatory barriers that sprout up. So, for instance, in some places, if you're going to open up something that you're thinking of as an outpatient surgical facility, but because of just the way the law is written, you're required to have a 24-hour emergency room. I mean, clearly that's like, and that would not be part of your intended, design of the system of the business that you want to open up. But if you're required to do that, that's going to kind of that'll scuttle the whole project because, like, where are you going to get your sort of like streamlined approach and your and not, that means that you have to hire more people. You have to hire people around the clock. It may make no sense to you. You might not even want to be in that business. But if that's part of the regulations that you're up against, that again, that's going to have a preventative effect from you opening up your surgical center.
And I think all of these kinds of barriers, ambiguities, limitations are important to consider because if one of the questions we're trying to answer is, well, why hasn't direct payment taken off as a model? Well, yeah, we have cultural barriers of people have certain expectations for how things are paid, and so do doctors. They're just used to working with insurance. There's just outright bans or laws like the ones that you're trying to change in New Hampshire that just make it impossible, even though it's not an outright ban on direct payments. And then there's insufficient data and talking points on the advocacy side. So all those things are going to have to come together for us to actually argue for direct payment as one amongst many different kinds of models that we hope to see in healthcare.
Yeah, absolutely. And just say it's a lot of work out there, but we've got answers for all of it. There's none of these are things that are stumpers that sort of leave us, without anything to respond with, whether it's data or arguments, good arguments that are health related or philosophical related or economic related. There are answers to these things, but it takes a lot of work. There's probably no magic words that I could say in the moment in a hearing where I've got like 3 minutes to talk, where I can reverse somebody's like deeply held philosophical perspective on, inequality. Isn't this is this creating a two-tier system, and that's an inequality problem? Like I can't change somebody's mind in a moment with one sentence on that, but we can address that over time with changing the way that these things are discussed. We can show that there are answers to that. Takes time. There are other things that are more like voting issues. Pointing out that there's no evidence that cash only facility opening up anywhere near a critical access hospital has ever caused a critical access hospital to go out of business, right? Like there are like kind of immediate voting issues and clarifications that you can make that'll hopefully sway the conversation in the moment like that. But some of these other things are longer term projects, and it just sort of goes with the project and the challenges that we're working on here.
And that's definitely one of the reasons why I'm interested not only in direct primary care, but all sorts of other payment models for healthcare and for healthcare reform, which is that a lot of the work remains to be done. And if you think that DPC is taking off and popular now, wait until we actually have winning arguments for it. Then we'll really see things change.
Totally. Totally.
And with that, I think that's a good place to end. I would like to thank our audience and till next time.
Thank you very much.
To stay up to date, subscribe to our show from whatever podcast platform you are listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.